for COVID, given the number of patients that we're currently seeing. And so we wanted to make sure staff are aware of the potential treatment options, as well as being able to inform their family and friends about these things. There are, of course, some limitations in the availability of some of these, but I'm sure our pharmacists and our infectious disease team will share with us kind of the best way to think about these things and access them. So for now, we'll turn it over to pharmacy. We're going to have kind of 3 brief presentations on this topic, so that everybody can get a broad perspective from pharmacy, infectious disease, and public health. So I'll turn it over to our pharmacy team now. And if you have questions, you're welcome to put those into the Q&A.
Hi, Dr. Garcia. Thank you for introduction. This is Joanne, one of the infectious disease pharmacists here at RUHS. Let me share my screen first. Can everybody hear me okay and see the presentation okay?
Yes.
Okay, perfect. So as Dr. Garcia has already alluded to, today we're going to talk about some updates regarding COVID therapeutics for the outpatient population. So I divided them into 3 broad categories. The first category is the monoclonal antibodies. And under this category, we kind of have 3 treatment options listed there. And we also have the IV antiviral option, which remdesivir being the only one under this category. And the oral antivirals, which is our newest kit on the block, consists of 2 different medications. The first one is a novel protease inhibitor combination with ritonavir, commonly known as Paxlovid. And then the other one is our molnupiravir. So this is just a general overview of our RUHS recommendation. So for the patients to qualify for these COVID therapeutics, first they need to have not required any hospitalization or oxygen and have risk factors for disease progression. And once they met those criteria, depending on their symptom onset, they will qualify for different therapeutic options. The oral antivirals are the strictest ones, with symptom onset within 5 days. And then followed by remdesivir with symptom onset within 7 days. And then our monoclonal antibody is kind of more lenient with symptom onset cutoff at 10 days. So in terms of what are considered risk factors for COVID disease progression, CDC has a nice website that they kind of list out all the risk factors that has been studied in meta-analysis and observational studies to be considered as risk factors for COVID-19 disease progression. So you can see that it's a long list, but basically obese patients, elderly patients, pregnant patients, any patients that has immunocompromised condition or certain comorbidities will basically qualify them as having risk factors for disease progression. So starting off with the monoclonal antibody category, so these drugs works by binding the spike protein receptor binding domain of the SARS-CoV-2 virus to prevent viral attachment to the host cells. And currently the EUA is approved for non-hospitalized and mild to moderate COVID-19 patients with high risk for disease progression. The most notable side effect associated with this class is infusion reaction. So the EUA does have a recommendation to do a 1-hour post-infusion observation for all the monoclonal antibody recipients. And currently, as you all know, with the Omicron variant, it is a variant that has a lot of the mutations that increases potential for immune evasion. So unfortunately, it kind of knocks out 2 of the monoclonal antibodies, the benamlivimab combination and the casirivimab, the REGEN-COV, are deemed to have no neutralization efficacy against the Omicron variant. So currently, the only monoclonal antibody that kind of retain its activity is the sotrovimab. So this is the main monoclonal antibody that we're using right now because Omicron variant is now the dominant variant in California. In terms of how do we actually access this medication, We do have California state-run monoclonal antibody clinic right here at RUHS Medical Center. We have a dedicated space for this patient. The clinic operates Monday to Saturday, 8 a.m. to 6 p.m. Except on holidays, there's no referral needed. The patients or the providers can call the number listed to schedule an appointment. And there are also other sites throughout the Riverside County that runs this type of clinic, including Desert Oasis, Eisenhower Medical Center, and the First American Wellness, just because they are certainly high demand for this monoclonal antibody clinic. I think our wait time at our current monoclonal antibody clinic is like up to 2 days right now. So if there's no space at our medical center, perhaps other sites will have more availabilities. Sometimes in the event that the California state-run clinic is full and the patient is already in the ED, our ED can run monoclonal antibody infusions for qualifying patients, but obviously we do not recommend sending the patients to ED exclusively just for monoclonal antibody infusion. And I do also wanted to talk a little bit about EvoShield, which is also a monoclonal antibody combination and does retain activity against Omicron. However, it's actually not approved for treatment of COVID-19 disease. It was approved for pre-exposure prophylaxis in patients who meet certain criteria. So usually any immunocompromised individuals who are deemed not going to mount an appropriate immune response to vaccination or who are not eligible for COVID-19 vaccination may receive this monoclonal antibody, and it can be redosed every 6 months as an IM injection. In terms of access, it does require doctor's referral, and currently there are 2 sites that offers EvoShield. One is the Desert Regional Medical Center, and the other one is the Eisenhower Infusion Center. Now moving on into IV remdesivir. So I'm sure most of you are pretty familiar with remdesivir. It's currently the only IV antiviral approved for the treatment of COVID-19 infections. And it basically works by interfering the RNA polymerase, leading to incomplete RNA replication of the SARS-CoV-2 virus. For the non-hospitalized patients with mild to moderate disease and risk of disease progression, the evidence for remdesivir is based on what the Pine Tree studies, which basically demonstrates 3 days of the remdesivir decreased COVID-related hospitalization or deaths among this population. So instead of for the hospitalized patients where we treat them for 5 days, for the non-hospitalized patients who fit those criteria, they may receive 3 days of the IV remdesivir. Now moving on into our oral antivirals, starting with Paxlovid, which is, as I said, the combination product of a novel protease inhibitor with a pharmacokinetic booster, the ritonavir. Its evidence is primarily based on 2 trials, the EPIC-HR trial. The HR stands for high risk, which basically shows 5-day treatment with Paxlovid decreased hospitalization in non-hospitalized, unvaccinated high-risk adults if it's given within 5 days of a symptom onset. In the EPIC-SR trial, which is what they call standard risk population, 5-day course of the Paxlovid also decreased hospitalization by 70%. And in those 2 populations, the non-hospitalized, unvaccinated, low-risk adults, and also non-hospitalized vaccinated adults with at least 1 risk factor for disease progression. And just keep in mind, these are all press releases. We don't really have access to any sort of preprint, so it's really just the information that was given from the manufacturers. But based on these 2 trials, Paxlovid is approved for the treatment of COVID-19 disease for the non-hospitalized population. One of the things for the clinicians to watch out for is that it does require renal adjustment. So for patients with eGFR less than 30, they might need to dose adjust Paxlovid. And for anybody with EGFR less than 30, it's actually not recommended. The other thing is that the full treatment course of Paxlovid consists of basically 3 tablets twice a day for 5 days. So you can see that the patient will have to take 6 tablets and basically 30 tablets per treatment course. So that's obviously pretty high of a pill burden for the patients to take. The second precaution with the Paxlovid is that due to the ritonavir component, which is a potent CYP3A4 inhibitor, it has high potential for drug-drug interactions. So there is a long list of control-indicated medications that's listed under the Paxlovid EUA. Just to name a few, antiarrhythmic such as amiodarone, anti-epileptic, antipsychotic, even HMG-CoA reductase inhibitors like the statins are all contraindicated with this medication. So that's definitely something the clinicians should watch out for before they prescribe this to their patient. Some of the resources that's available to the clinicians to do this drug-drug interaction check include the actual EUA fact sheet itself. It has a nice table that kind of listed out the contraindications. We have a similar listing under our RUHS outpatient guidance. Then there's also this online drug interaction checker through the University of Liverpool. So I just kind of provided this screenshot here to kind of show you what it looks like. So you can basically enter the Paxlovid under the drug section, and then you can basically just enter any sort of the medications that you want to check for drug-drug interactions under co-medications. And then this checker will basically tell you do not co-administer or there's potential interactions, consider dose reduction, etc. Now moving on to oral molnupiravir. So this is a prodrug analog that interferes with viral replication by causing lethal mutagenesis. The in vitro data demonstrated really potent inhibition against the SARS-CoV-2 virus. And its EUA is based on what they call the Move Out study. And again, similar to Paxlovid, this is based on a press release, not necessarily any sort of preprint publication. The Move Out study basically shows molnupiravir for 5 days decreased the hospitalization by 30% in the non-hospitalized high-risk adults with COVID-19 infections, and again, within 5 days of the symptom onset. So you can see that the stringent symptom onset criteria is really just based on the study. There's actually a separate move-in study for the hospitalized patients, but it was actually stopped due to interim analysis showing no benefit. The molnupiravir is dosed as 800 milligrams PO BID for 5 days and is actually 4 tablets BID for 5 days. So again, quite a bit of pill burden for the patients. The nice thing is that it doesn't require any renal or hepatic dose adjustment, but it does come with some safety concerns. The first one is the mutagenesis concern, just based on its mechanism of action. The manufacturer itself has conducted pretty extensive preclinical mutational toxicology assays, which basically concludes that it's not mutagenic. An FDA review panel also concludes that the risk of mutagenicity is pretty low in humans, especially with short course of only 5 days. The other concern is the bone, cartilage, and embryonic toxicities that they observed in animal studies. And obviously the pregnant patients were excluded from the trial. So the EUA actually required counseling the potential risk and the use of effective contraceptions during the treatment and 4 days after the final dose for any female patients with childbearing potential, as well as male patients with reproductive potential who are sexually active with females of childbearing potential. Pregnancy itself is not a contraindication, but the providers do need to document the known potential risk and benefit are discussed with the patient. In terms of how do we access the PO oral antivirals, The California Department of Public Health has received a limited supply, and they do provide a list of the pharmacies that has received these allocations on the website that's listed here. This list does not really guarantee availability, so the prescribers are advised to check with specific sites for drug availability prior to prescribing. There's also a second avenue potential federal allocations, which we are kind of pending further information. So here is a list of the pharmacies throughout Riverside County that has received CDPH allocation. So this will be the list that you see when you go to our website. And here is actually a really nice website that the providers can actually search different regions for the locations that has received federal allocations for oral antivirals. So here is just a screenshot, but you can see I type in Riverside, CA, United States, and they basically have like the pop-ups of different locations that has received allocations and how many they have already allocated. And then as far as for our CHC providers, I just want to do a plugin for our IT team. They have made a smart set that consists of the COVID-19 diagnosis and the Paxlovid order, as well as the patient education section. So definitely a tool that the providers can use. And then lastly, to just kind of summarize what I've just gone over. So again, the patients who will be eligible will be patients who are obviously COVID positive with mild to moderate disease, not requiring oxygen, and with risk factors for disease progression. For anybody who's age above 12, depending on their symptom onset, they can be eligible for the oral antivirals, the Paxlovid, the IV remdesivir for 3 days, or the sotrovimab. And in terms of the molnupiravir, it's only approved for age greater than 18 years old. So here is kind of like a flowchart created by the CDC to kind of help guide the providers on how to prioritize all the COVID therapeutics. So basically, if you follow a flowchart, the first thing to kind of decide is the symptom onset. Obviously, if the symptom onset is past the 5 to 7 days and is already into the 10 days region, then the only option will be the monoclonal antibody, the sotrovimab. But if the symptom onset is within 5 to 7 days, and the patient kind of met that 5-day symptom onset and renal cutoff, then they should be eligible for the oral Paxlovid. Obviously, they can also be eligible for sotrovimab and remdesivir, but the oral antiviral kind of is the more preferred option there. And if the patient somehow is not eligible for all three, and they are greater than 18 years old, then they could potentially be considered for molnupiravir, depending on the pregnancy and the contraception. So this is just a more simplified version of that CDC guidance. So as I said, depending on the symptom onset, if it's less than or equal to 5 days, then the first thing we kind of think of will be the PO antivirals, the Paxlovid, as long as their eGFR is greater than 30 mL per minute. And obviously we want to check for drug-drug interactions. If the Paxlovid or sotrovimab is not available, or the patient has certain contraindications, then we can consider molnupiravir if they are greater than 18 years old. And obviously we need to consult on the teratogenicity potential. If the symptom onset is less than 7 days, then the option will be sotrovimab or remdesivir or the oral Paxlovid. And then again, symptom onset less than or equal to 10 days, sotrovimab will be your option. And in terms of insurance coverage, all the EOA COVID therapeutics should be free of charge to patients. Patients may be subject to administration fee or dispensing fee. So for example, the charge for getting the injections or getting infusion or pharmacy dispensing. So that concludes my presentation. I can take any questions at the end.
Thank you, Joan. I just wanted to point out that somebody had raised a really valuable question about temporarily discontinuing contraindicated medications while using Paxlovid. And Dr. Chevinsky answered that with some of the NIH recommendations around options for that. So I just wanted to make sure everybody noted that in the question and answer section of the webinar. I did have a quick question for you. Thank you for providing us with kind of guidelines on how to approach patients that may benefit from these medications. What are the kind of the common side effects that patients are experiencing with all of them?
So I would say for the monoclonal antibodies, as I said, like the most common side effect is the infusion reaction. With the IV remdesivirs, the more common ones will be like liver enzyme derangements. In terms of like oral antivirals, we don't really have a lot of experience for inpatients. So I wouldn't say that we have a lot of experience in terms of firsthand observations for this type of medication as of right now.
Okay, thank you. Well, why don't we have Dr. Wang, I believe he's there with you, and so we can have him kind of discuss his portion, and then after that we'll go to public health and Dr. Chevinsky.
Yeah, thanks, Dr. Versius. I don't actually have a presentation that's going to cover anything more in depth than what Joanne's already put out. It's super detailed. I think from the ID standpoint, with Joanne's always been very involved in our one of our ID pharmacists here, especially with these oral regimens, which I think Dr. Chevinsky will probably mention as well. I think the drug-drug interaction with Paxlovid really needs to just be seriously considered, right? A lot of these patients who may have COVID and qualify have significant comorbidities, and they're often maybe on multiple different medications. So again, making sure to evaluate for any drug interactions, especially with that ritonavir in there, I think is really critical to make sure that when you prescribe this is done safely and efficaciously at this point. I do want to again remind everybody there's still the monoclonal antibody clinic that's set up through the state here, not only throughout the county but our UHS. So that's always a resource. And again, it's call the number. For the providers who are listening, just remind your patients, because there's such a demand right now, you're usually not going to typically get a person, at least at our monoclonal facility. So leave a message with a callback and they will call you back. I know they've doubled from what Dr. Masiska, who's been telling me, the appointment times and scheduling here within the last week, but there's still quite a demand there. So again, just to let people know, you're typically not going to reach somebody by phone, so please leave a message for that setting. And then the remdesivir that Joanne talked about, it's almost like a fail-safe. It's very hard to do in an ambulatory setting, a 3-day course. We've done that occasionally on the inpatient side, and frequently if we've had to in the setting that we've not been able to do monoclonal antibodies when somebody's had indication for it and is being admitted for, say, non-COVID related reasons with maybe some runny nose or some mild fevers and has high risk factors. But I think with the oral therapeutics, which has kind of been exciting from that standpoint, because that's far reaching, it's the pill, you're not having to go anywhere to get an infusion or anything. Just keep in mind the drug interactions, I think is really, really important.
Thank you, Dr. Wang. All right, so we'll turn it over to Dr. Chevinsky, who's going to kind of share with us public health's approach to access to all of these therapeutics, as well as I think some additional things. So thank you for joining us, Dr. Chevinsky.
Sure, and just before I go, I saw the meeting goes to 12:45. Do we have a little bit more time than that?
Yeah, we can go a little bit longer. Mm-hmm.
All right, I'm going to share my screen. And are you able to see the presentation?
Yes, thank you.
Perfect. So hi, everyone. I'm Dr. Chevinsky. I'm one of the Deputy Public Health Officers with Riverside County Public Health. I was fortunate to present last week with Dr. Chiu, and she does a great job. So I think from my side, I have some similar slides, and we can go through those a little bit more quickly because Dr. Chiu did such a great job with that overview. And I'll try and talk a little bit more about the public health side, the allocation, what numbers are looking like around the county, and priorities around therapeutics. So first off, I'll just go through, as you all may be aware, there are multiple outpatient treatment options for people at the highest risk for severe disease. Dr. Chiu covered those quite well too. And so, of course, with those that have no illness, we have the, COVID-19 vaccines as prevention. We also have the Evusheld that I did want to confirm that there is not an administration fee or any additional fee for our regional centers that are giving the Evusheld. And those are currently up and ready and active. So those are ready for any patients that are immunocompromised to go get that Evusheld. Post-exposure prophylaxis, we're really not doing very much of that anymore because of these two medications not being active against Omicron. But the mild to moderate symptoms, we have the monoclonal antibodies. As Dr. Chiu mentioned, sotrovimab is that major one that's active against Omicron. We are looking out for other facilities that are able to identify, for instance, S gene dropout and Thermo Fisher testing that can help identify whether or not this the variant is Omicron or whether it might be Delta, because we are able to get limited quantities of REGEN-COV and the BAM-EDI for for facilities that are able to differentiate, and if they do have a positive Delta, then they would be able to give one of those other two products. But overall, as a state, those products are no longer being allocated at this time, unless for those specific instances. We have the sotrovimab, which is in quite small amounts throughout the county. And we have the oral antivirals, the Paxlovid and molnupiravir, which we have allocated to the federal partner sites, which is primarily CVS's and Rite Aids, in addition to 10 equity sites that we've identified to fill in gaps. And then the remdesivir is the other treatment option. So as you all may have heard, there's therapeutic shortages across the United States. So that's happening in many areas, California included, Riverside County included. And so part of what our role as public health is to do is to make sure that allocations are equitable. So both temporal and geographic equity is considered. And so our prioritization schemes consider how we can ensure that people that might otherwise have barriers would have access to these products. So things like ensuring that the facilities are not charging costs, that we've focused on facilities that don't charge an administrative fee, focusing on locations around the county to ensure that throughout the county there is good access to these different products. And then in addition, we have also set up with transportation facilities through EMD that if there are patients, for instance, or even if any of your patients, if in instances where they may, for whatever reason, not be able to get transportation to a facility to get monoclonal antibodies or one of the other therapeutics, on a case-by-case basis, we can also organize that. So here's just a look at what we're talking about when we're saying a shortage. So it goes through the amount of each of these different products, how much we're getting and what's being given out to the state and to the county, and then how much ends up trickling down to the different facilities. So there are multiple issues that and factors that contribute to the shortage. So on one hand, we have ramp up production of allocation of oral antivirals, and we're still getting quite a few amounts. So the Paxlovid, there's around 6,000 treatment doses that are being allocated to California. We're getting around 480 of those treatment courses. So each pharmacy ends up getting around 20 to 60 courses or so. So that's the reason that we're saying, we encourage to call ahead and see whether those pharmacies still have the Paxlovid within their pharmacies or whether they've run out. For molnupiravir, we're getting quite a lot more. So we get 2,300, but again, that's a medication that's really last case scenario if all the other treatment options are not available. And there's some evidence suggesting that in people that are vaccinated that would anticipate to have a decent response to the vaccine, that the molnupiravir might not add that much additional protection for those that are diagnosed with COVID because of that limited efficacy or effectiveness of 30% reduction. We also have ramp up in production and allocation of Evusheld. So small amounts, although this we have started to see some improvement. So right now our 2 facilities are well stocked. So if your patients are immunocompromised, requiring Evusheld, and if you're having any trouble with facilitating with those 2 different centers, you can also contact us, and we're happy to help with those connections. And then at the same time, of course, the effectiveness against Omicron, we're getting the decreasing supply of the REGEN-COV and BAM-EDI. Just as of this week, we found out that we'll not be able to order more unless for that specific instance where facilities are able to differentiate on the spot against the different, which variant is present. And we have ongoing shortages of sotrovimab, with news that that likely will not improve, at least for a couple months. So we're getting around 200 courses. So this was for last distribution. This most recent one, we got around 200 courses, and that's spread out around the county. So each facility is getting around 60, 70 doses to cover all of the patients at the regional center. So still few amounts. And then also all this is in the face of increasing cases throughout the county. So increased demand, increased need. So in terms of preference, and this is what FDA recommends as the order of preference in the NIH for treating patients that are positive with COVID that are at risk for severe disease. So first is going to the Paxlovid, and I'll echo the statements that we still need to be mindful, careful about medication contraindications, but it's worth it to do that evaluation of the medication list, that if they are able to get it and within the 5 days, it would be the most optimal, the best choice to start off with the Paxlovid as the first option, and then start ruling out thereafter. Our sotrovimab is still in a state of shortage. So if the Paxlovid is not available, then you go on to see about the sotrovimab. If for whatever reason they're not able to get in for the sotrovimab, then you would go down to the remdesivir option. And then finally molnupiravir as the last option. You're going to consider when you're making these decisions, thinking about things like clinical efficacy of treatment, the availability, feasibility, which is often a challenge with the remdesivir as mentioned, and potential for significant drug-drug interactions like the Paxlovid. Some of these can be worked through. So on the website that I posted in the answer to the question, the Q&A, there are suggestions around certain medications that you might be able to put them on pause during the time that the patient is on the Paxlovid treatment, and then for potentially a few days afterwards, potentially stopping it before. So keeping in mind what the half-life of the other drug is, there might be ways that you could still give the Paxlovid. And then also that regional prevalence of Omicron, which we know is on the rise here. And the time from symptom onset might also influence that treatment option. So Dr. Chiu did a good job walking through this algorithm. So this is the same one that we're using and that we're supporting as well. As Dr. Chiu walked through it, I'm not going to walk through it as well, but going down these different pathways of can help with identifying which might be the best choice, but typically trying to see if Paxlovid can be an option before moving down to the other options. So looking at how these different therapies stack up is a summary chart. Essentially what we're seeing is that the Paxlovid, sotrovimab, remdesivir, these are all our high effective medications. The molnupiravir, that's down there at the 30%. The remdesivir, that 3-day infusion makes it a little bit more challenging operationally. For the Paxlovid, the drug-drug interactions makes that part challenging. The sotrovimab is often easiest, lowest interactions, but often also the one that's in the most shortage. So that's the challenge there. The molnupiravir, that one's probably the most available, but least effective and concern in pregnancy and the immunogenicity. So when there are logistical or supply constraints, when it's, we have to start thinking about triage. What the FDA and a panel suggests is treatment over post-exposure prophylaxis, which we're already in that situation now. Treatment of COVID-19 in unvaccinated or incompletely vaccinated individuals with clinical risk factors for severe illness, and vaccinated individuals who are not expected to mount an adequate immune response. So those would be the higher priority, higher risk. And then when it comes to Evusheld, those that are severely immunocompromised over those are moderately immunocompromised. Right now, we're in a good situation with the Evusheld. We're in a good place for patients to be referred over. And then there's, more specific guidance on making those different decisions. Here are just some different resources, the fact sheets for providers, the same phone numbers for our county regional sites, our Evusheld sites, the list as Dr. Chiu mentioned about the oral antiviral sites, some of the other resources, and all of this information can be found on our website. So these are the same as Dr. Chiu mentioned, our different sites around the county for the oral antivirals on our website. So if you go to rivcoph.org/coronavirus/treatment, we're continually working on improving that website. So on there we have our flyers. This is an updated flyer that we recently posted, just outlining for people that are lower risk, young and healthy, then it's over-the-counter treatments, higher risk, older underlying conditions. Then it's the oral antiviral, monoclonal antibody, remdesivir, the highest risk, the pre-exposure prophylaxis of the Evusheld, the other treatments for testing positive, oral antiviral, monoclonal remdesivir, gives the information of the phone numbers and the contact information for the different sites, as well as our contact information. We have this flyer that you may have seen for the monoclonals. We updated the different locations for the different monoclonal sites. We have one that we just recently created as well for Evusheld. It's not posted yet, but will be posted soon. And then we're on the lookout for facilities that are doing the outpatient remdesivir in order to be able to add it to our circulate information to providers about where their patient can get outpatient remdesivir if the other options are not available. So this is our contact if you have other questions, but that's all that I have. Thank you.
Thank you, Dr. Chevinsky. I want to put a plug in for people raising questions in the question and answer section. So please put those in. Thank you for those of you that have stuck on with us, given that this is a little bit longer webinar today. While we wait for any potential questions to come in, I wanted to see if Dr. Sang had anything that she wanted to add.
Thank you, Dr. Versio. I think this is really important as a tool for us to use as we're thinking about keeping patients out of the hospital. And so, in terms of, for those who are on RUHS Epic, this is orderable already within our Epic systems. But as we think about how we can help patients, who are being diagnosed with COVID, thinking about these therapeutics as options and helping our patients navigate to get to them are going to be really important over the next few weeks as we try to help offload our hospitals that are already very full. So, if we can if we can help in any way, or if there's any additional questions, please reach out to us. Thank you.
Thank you so much. Looks like no specific questions have come in, so thank you to all the panelists. Really appreciate all of your expertise and wisdom and kind of approaching this issue. And thank you for joining us today. Hope you all have a wonderful week.
Thanks so much.
Thank you.